Good morning everybody. I am Dr. K. Vinod, Professor of Anesthesiology, and today for the Anesthesia class we are going to study about the basic principles that are involved in anesthetizing a patient posted for rigid bronchoscopy. Rigid bronchoscopy is a procedure that can be done on an outpatient basis as well as for procedures which take longer duration. So we have to tailor the anesthesia according to the needs of the rigid bronchoscopy. Additionally, a rigid bronchoscopy is a procedure in which the definitive airway may not be established, which leads to a lot of trouble for the anesthetist in anesthetizing them safely. And at the end of this topic, the student should be able to describe the principles that are involved in anesthetizing a patient for rigid bronchoscopy. First, we should be knowing about the indications and contraindications for the usage of rigid bronchoscopy. In recent times, the introduction of flexible bronchoscopy has made the interventional procedures in the trachea as well as in the lungs quite easy. But there are conditions in which the flexible bronchoscopy may not be useful and only rigid bronchoscopy has to be used. And such conditions are: the first one is a tracheal tumor excision, 2, tracheal stenting, 3rd, tracheal dilatation in patients who have undergone stenosis following acid consumption, and management of hemoptysis. There are 2 very important contraindications for the usage of rigid bronchoscopy. The first one is unstable cervical spine and the second one is restricted mouth opening. See, when you are doing a rigid bronchoscopy, you need to extend the patient's neck so as to adequately visualize the bronchus. In case if it is not possible in such conditions, in patients with unstable cervical spine, this manipulation of the neck might lead to quadriparesis. And the rigid bronchoscope is a rigid metal tube. So for its entry into the mouth, we need an adequate mouth opening. So it can never be done in a patient with restricted mouth opening. So we can generally divide the challenges faced by the anesthesiologist into general challenges as well as the challenges which are very much specific for anesthesia. The first, let's have a look at the general challenges. The first one is the common airway sharing between the anesthetist and the surgeon. The second one is risk of loss of airway patency. See, in patients with large tumors in the trachea, whenever the anesthesia is induced, there might be a collapse in the airway which might prevent us from inserting this rigid bronchoscope. The third one is unconventional modes of ventilation. See, whenever we are using a rigid bronchoscope, we cannot secure the airway with the cuffed endotracheal tube or an LMA. So in such conditions, the airway maintenance has also to be done through the rigid bronchoscope, and in the absence of on the cuff, ventilation might be challenging. And whenever we are doing any procedure in the head and neck, obviously a deep plane of anesthesia is very much important. Now let's have a look at the father of endoscopy. So Dr. Chevalier Jackson was the first person to devise the rigid bronchoscope, and he has been using it for more than this usage of this device for more than 100 years. So Chevalier Jackson invented the bronchoscope, and the modern day bronchoscopes are nothing but a slight modification of his invention. So this picture shows us the rigid bronchoscope which was used in olden times. So the same picture, you can see the proximal end as well as a distal end. So this picture shows the rigid bronchoscopes which are used in modern days. So you can see a proximal portion as well as a distal portion. The proximal portion is called the head and it has 3 orifices, whereas the distal portion has a bevel. So let's have a look at the structures that are present in the head of the rigid bronchoscope. So the head of the rigid bronchoscope is equipped with 3 ports. The first port is the ventilation port, through which the positive pressure ventilation or the jet ventilation is being administered. The second port being the broad axial axis, through which the camera as well as the instruments, the stents, the graspers will be introduced. And the third oblique channel you can very well see is the one which is blue in color. See, that is mainly used as a suction port, or it can be used as a laser fiber port. Now coming to the distal end. So the distal end is always beveled, and this is the part that is introduced into the patient. And the reason for having a bevel is to elevate the epiglottis during insertion of the bronchoscope, to cut or core the tumor edges, to gain access in tight luminal stenosis, to initiate dilatation, and to elevate the stent that is embedded in the airway mucosa. So what kind of anesthesia is preferable in such patients? So the first one is we need a rapid induction. We want the patient to be under immediately. 2, we need to establish good ventilation and oxygenation. Third one, just because we are doing a procedure in the airway, definitely there should be no cough reflex, and maintaining this kind of a plane without muscle relaxants is quite a challenge. And fourth one, we have to have reduced airway secretions. In the presence of excessive airway secretions, it might not be possible to conduct this procedure. So we have to give a good anti-sialagogue agent prior to the bronchoscopy. Fourth one, just as I mentioned in the previous slide, mouth opening needs to be adequate. In addition to that, we need to have a good mandibular and glottic relaxation for introducing the rigid bronchoscope. And the last 3 points are particularly important in patients who are undergoing rigid bronchoscopy as a part of a daycare procedure. So we need to have a quick and smooth reversal, minimal post-operative complications, and minimal hemodynamic shifts for us to discharge the patient on the same day of the procedure. This slide shows the positioning of the head of a patient who is undergoing rigid bronchoscopy. So it is very clear that it needs a lot of extension for introduction of the scope. So this clearly states that patients with unstable cervical spine are not suitable candidates for undergoing rigid bronchoscopy. Okay, now let us come to the challenges that are very much specific to anesthesia. So the first challenge is the circuit leaks, 2, airway fire, third one is hypotension, fourth one is acidosis, fifth one is probable drug overdosage, propofol infusion syndrome, and the last one would be a need for postoperative ventilation in patients undergoing prolonged duration rigid bronchoscopy. So the first challenge is circuit leaks. See, generally when we are administering general anesthesia in operation theatre, the airway is usually a cuffed endotracheal tube. So whatever gas that is given to the patient, anesthetic gas, which when taken back from the patient is passed through a scavenging system so that the sevoflurane and nitrous oxide are not let into the ambient theatre atmosphere. But in the presence of a rigid bronchoscope, there will be no such endotracheal cuff. So obviously the exhaled part of the air which contains nitrous oxide and sevoflurane will be contaminating the operation theatre. So whenever the anesthetist or the theatre personnel are exposed to higher concentrations of sevoflurane and nitrous oxide, this might lead to a mild confusion, headache, memory problem, fatigue and attention problems for the theatre personnel, which they should be very much aware of. 2. the most dreaded complication while doing rigid bronchoscopy, diathermy or laser procedure is the chance of airway fire. So what we are seeing is a triangle which is nothing but a fire triangle, which is very much similar to a Virchow's triad in pathology. So what we have to know about this is, see, there is a chance of airway fire when the surgeon is using a diathermy to cauterize a bleeder in the airway while the procedure is being done. So the one which initiates the fire is the ignition source, which comes from the surgeon, and the structure that burns in the presence of the fire is the gauze or cotton or blood jets or the endotracheal tube, which is secured in the airway. And the third one is the oxidizer or the catalyst, which will enhance the fire that is caused by the ignition source. And most of the oxidizers or the catalysts are the anesthetic gases which we use, namely oxygen, nitrous oxide. So whenever we are planning to do a diathermy or when we are planning to use a laser to burn an area or to resect a tumor, the surgeon should inform the anesthetic team and the nursing team before using the diathermy. So at that time, the nursing team will fill that area with cottons and gauzes which are soaked in saline so that they will not catch fire. And additionally, what the anesthetist need to do is he should use oxygen concentrations of less than 35%. So whenever the inhaled concentration of oxygen is less than 35%, the chance of catching fire during the usage of diathermy is almost obsolete. So we are very much safe in doing it. While coming to the next complication, which is hypotension. Hypotension is a frequent, complication or a side effect that is obviously seen in patients being anesthetized for rigid bronchoscopy. See, we will not be, very much comfortable using a muscle relaxant when rigid bronchoscopy is used. So, in order to compensate for the usage of muscle relaxant, we have to use other agents to deepen the plane of anesthesia. So we are left out with two drugs, mostly propofol and fentanyl. So propofol, we all know, is a vasodilator as well as it will reduce the cardiac contractility. While coming to fentanyl, it also will cause vasodilatation, thereby leading to hypotension. So the management of this hypotension is proper preloading of the patient, and in spite of the preloading and adequate fluid administration, if there is still a fall in BP, we can use vasopressors to reduce the fall in BP. The next complication is acidosis. So whenever the patient is undergoing rigid bronchoscopy under anesthesia, they will experience both the respiratory and the metabolic acidosis. So due to the absence of the cuff, there will be inadequate minute ventilation, leading to retention of carbon dioxide, leading to hypercarbia. So hypercarbia and acidosis will lead to arrhythmias, reduced myocardial contractility and hypotension, leading to a vicious cycle. Additionally, this hypercarbia will also cause an increase in intracranial pressure as well as increase the pulmonary vascular resistance. And additionally, metabolic acidosis will also be seen in such patients. The main reason being the hypotension caused by the anesthetic agents. That can lead to hypoperfusion, which leads to lactate buildup in the tissue, leading to a pH of less than 7.35. And the body actually tries to compensate by reducing the carbon dioxide, but anyway, under anesthesia, these reflexes will not be very much functional. And the other important complication is propofol-related infusion syndrome. So whenever we are not in a position to use an inhaled agent or a muscle relaxant, we need to give a sedative drug, namely a propofol, when it is used in higher concentrations, and that might result in a severe high anion gap metabolic acidosis, which is called as propofol-related infusion syndrome. So the most important inciting agent is the dosage of propofol. Whenever the dosage of the propofol is exceeded within a short span of time, this will lead to this infusion syndrome. The other symptoms that are seen in as a part of propofol related infusion syndrome are rhabdomyolysis, hyperkalemia, acute kidney injury, elevated liver enzymes, and cardiac dysfunction. So the best way to avoid this syndrome is that we should be very much careful with the usage of this drug, and we should actually can use other agents like dexmedetomidine in small doses to replace, and also supplement with opioids to reduce the dosage of propofol. So from this class, it is very clear that while providing anesthesia for a patient undergoing rigid bronchoscopy, it is not difficult, it is slightly different. So in case if you learn about these differences, it will be a relatively simple and a safe procedure. Thank you.